and you've joined us. Are you standing in for Micky Tripathi, or is Micky behind the screen?
No, I'm here, Denny.
Micky, hello. Welcome to see you. Thank you for joining us.
Thank you.
Why don't we get started, ladies and gentlemen? My name is Denny Brennan. I'm the Executive Director and CEO of the Massachusetts Health Data Consortium. And I'm excited to welcome you to the final installment of the Road to Interoperability series. We were pleased and privileged to have both Micky and Alex join us at the first forum session in January this time last year, and we're delighted to have them back, especially in light of the news that is emerging and has emerged in just the last 24 hours about a certain final rule, which we'll certainly talk about today. Let me tell you a little bit about today's session, and then we'll get started post-haste. Today's session will last for an hour, but MHDC staff will stay for an additional 30 minutes so that if you'd like to continue discussion, if you'd like to request information of us, we will certainly be diving into the recently final rule, but we welcome you to stay for an extra 30 minutes. Today, please share your thoughts in the Q&A. We have currently 130 people online, and having people speak up is probably a little more difficult to control than is normally the case. So please use the Q&A box if you have a question, and we'll take your questions both during the presentation if they're relevant to the topic at hand and immediately afterwards. We will be recording, as you know, this session. It is recording now, and it will be available on our website at mahealthdata.org. And lastly, we ask you to take a very brief pop-up survey that will follow the end of today's webinar. Now I'd like to introduce David Carusio, our chairman of the board and the chief technology officer at Point 32, to say a couple of words to get us introduced.
Thank you, Denny. I just wanted to thank and say Happy New Year to everyone who's joining us. And thank them all for taking time out of their day to join us for this great session. It's fantastic to have Alex and Micky back, bookending what's been a great series over the last 12 months. And happy to hear their updates in light of the final rule yesterday, and look forward to the session. So let's kick it off.
Thank you, David. Unfortunately, Bill Young will not be able to join us today. He just recently had surgery and is recuperating, but he sends his regards, Alex, to you, and Micky to you as well. So let me tell you a little bit about our speakers, the minimum necessary, because most all of you know as much as anyone else about our guest today. Let me introduce Alex Mugge. Alex is the Chief Health Informatics Officer at the Center for Medicare and Medicaid Services, where her team leads the interoperability and health IT efforts for CMS. Micky is the National Coordinator for Health Information Technology at the Office of the National Coordinator, or the ONC, where he leads the formulation of federal health IT strategy and coordinates federal health IT policies, standards, programs, and investments. Just prior to being a part of the Health and Human Services Secretariat, Micky was the Chief Alliance Officer for Arcadia, and especially relevant to us was the Chief Executive Officer of the Mass eHealth Collaborative, an organization with which we at MHDC partnered for many years. So moving forward, let me start by describing how we organized this session. We have 3 questions that we ask folks, and in light of yesterday's news, our questions remain relevant, and we'd like to start with the first question, if we will. And we'll start, Alex, with you, and then Micky, we'll turn it to you. What are the ONC and CMS's, I won't say 2023, I will say 2023 through January, whatever today's date is, the 18th of 2024, what are your interoperability accomplishments you think will have the biggest impact? And as we move into 2024, and this is especially important as we think about the rollout of the recently finalized rule, but also what we anticipate coming from ONC, what are your plans, goals for, important actions in 2024? Alex, let's start with you. Talk to us about this most momentous announcement yesterday, what it portends, and the work in 2023 that led you to get to this point.
Yeah, thank you, Denny. And I will say that when I saw the question, I thought, I guess releasing the rule yesterday doesn't count as 2023, but we did process all of the rule comments in 2023. So we're still going to call it a 2023 and January 24 accomplishment. So the CMS interoperability and prior authorization final rule was released yesterday. That's after processing the 900 comments that we received on the rule in 2023. The policies in that rule are very much influenced by stakeholder feedback and the public comments that we received, and adjustments were made to the policy to account for those comments. So I think our team feels a great sense of accomplishment in that we got these policies out the door, but also that it was we were able to capture so much stakeholder feedback and the final policies and what is represented in that rule. I will also mention, I said this yesterday when we were doing the rule announcement. We don't usually at CMS, give necessarily rule writing credit. It's not, while we have authors of the rule, it is a team effort. But I do want to highlight the number of people that worked on the interoperability and prior authorization rule, because if you look at the list of contacts in the introductory section, you'll see that just about every part of CMS has something in this rule, from the payer programs to provider programs for clinicians, for hospitals. It was all part of this final rule, and everyone came together to work on this because these policies are so important for prior authorization reform and for making healthcare better going forward, as we believe that these policies will do. So there was a lot of collaborative work that went into it, and we feel very fortunate that those teams were able to come together and finalize this policy in a timely way. So I will highlight that list of contacts. All of those folks, plus many more, contributed to the drafting of these final policies, and so I do want to give them a shout out. Also, along with the announcement of the rule, we did indicate that we will be pursuing prior authorization of medically covered drugs. So when we were drafting the policies for the interoperability and prior authorization rule, we stayed away from drugs because prescription drugs have, they have timeframes, they have standards, they have many policies that are already in place. We didn't want to confuse any of those policies or make changes to those policies, and we really focused on medical items and services. But we understand that left a gap for those drugs that are covered under the medical benefit. And when we rolled out the rule yesterday, the administrator announced that we are looking into prior authorization drug policies for those medically covered drugs. So that's something that you can look forward to seeing from us in 2024. Among other accomplishments, I want to highlight that we did process also many comments on the National Directory RFI. That National Directory effort is ultimately intended to support interoperability by connecting folks in the digital space. So making digital endpoints available publicly, making sure that provider and payer data is accurately represented through a national directory. And we believe that will support interoperability and better connections in the future. So I'm going to count that as a 2023 accomplishment as well. There's a lot more to come on that particular effort and some of the other things that we're working on here. So I think we'll have another exciting year in 2024. But the final accomplishment that I want to mention, and I'm not just saying this because Micky is on the phone, but I do want to highlight our awesome collaborations with ONC this year. I think that has been a major success. We've had a long-standing relationship with ONC. We've partnered with them on many things in the past, but I think it's never been stronger than the partnership that we have now. With ONC really pushing forward with TEFCA, we've met with all of the QHINs. We've collaborated on the rules that we've released this year. So Micky's team has already released one rule and has another one upcoming, and we've really been able to collaborate on each of those and partnered with us on our interoperability work and our digital measures and lots of work that's going on here at CMS. So I think it's a really good sign moving forward that these two agencies have been able to collaborate in this space so much. And again, you'll see a lot more of that in 2024.
Thank you. That's excellent. Micky, talk to us about 2023 and 2024.
Okay, great. Can you hear me okay?
There you. Yes, we can.
Okay, great. Yeah, and if I look cold, it's because I'm on the Cape and the house is only very reluctantly waking up. So I think it's 16 degrees here right now. I'm really delighted to be here. First off, I just want to just build on what Alex had just said. We just have such a great relationship with CMS, and I think Alex herself and the team deserve a tremendous amount of credit for the work that they do every single day that only appears in public once in a while, as exemplified by like the interoperability rule. But there is so much work behind the scenes to to get that forward, and I think it's just I just think that we all owe a huge debt of gratitude to the work that Alex and the team have done to bring this, because it's such an important part of the interoperability puzzle that we're all working on. We're really excited, enthusiastic about it, and really excited to help support what CMS is doing on that side of the interoperability equation. As we talk about 2023 accomplishments, we were sort of had the big accomplishments until Alex released the rule just last week or something. So, but I'm delighted that she stole the thunder.
You've been upstaged. What can I say? You've been upstaged.
That's right.
I'm sorry.
I guess I would start at the beginning of the year. As 2023 was the year of availability of certified FHIR APIs in all certified electronic health record systems. So as of December 31st, 2022, meaning as of January 1st, 2023, all certified developers were required to make available to their customers a standard FHIR API that made available the US CDI, the US Core Data for Interoperability. And that certification covers 97% of hospitals and 80% of ambulatory providers. So that's huge. I mean, as FHIR has been sort of in adoption phase for a while, and has gotten rapid adoption. But the fact that it's now fully instantiated in regulation as a regulatory requirement, I think kind of brings it over the line in terms of making sure that you have that availability. Now we know that there's still it's going to take a while over the next year or two or three for that full adoption to take place in the installed base, because the requirement from ONC was that it be made available to customers. Of course, customers don't, we can't force customers to take that version. CMS, with their payment rules for providers who participate in certain payment programs, are required to have that version of their software in place by the end of the last quarter, by the end of third quarter, I think, of calendar 2023. So you've got those pieces now in place, and I think we're going to hopefully see a tremendous amount of activity now that we're able to build on that FHIR foundation that's now been laid across the ecosystem. I should point out that the FHIR APIs, while we certainly have a focus on patient access, those FHIR APIs are by regulation, are controlled by the customer. And the idea is that those should be available for whatever the customer chooses. So not just B2C use cases, which are very important, but also B2B use cases, provider to provider for continuity of care, availability to payers, to help facilitate better integration and better collaboration among payers and providers. Public health would be another example where we could leverage those FHIR APIs. So that's one I think very important and huge accomplishment in 2023. The other one, and I'm kind of going a little bit chronologically here, is we released the draft, and this is the department. This is a department level rule, released a draft rule for the so-called appropriate disincentives as a part of the information blocking regulations. So just to back up for a second, the 21st Century Cures Act had requirements related to the prohibition on what was called information blocking, which is the interference in the access, exchange, and use of clinical information or electronic health information among authorized parties, including patients. And the law put into place authorities for penalties for actors who were found not to be in compliance. And that was for certified technology developers and health information networks. But they put in the secretary's lap defining what were called appropriate disincentives, which would be penalties on providers who were found to not be in compliance. So we worked very hard since coming into the administration to define those because it's a lot of hard work. It's very complicated. We also think that that's an important part of everyone's accountability to achieve the goals that we want to be able to accomplish with respect to information sharing as envisioned in the 21st Century Cures Act. So in October, we released a draft rule, which is an HHS level rule. It's ONC was the author. The secretary asked us to sort of author the rule, but it was really with contributions from a variety of agencies: CMS, the Office of Inspector General, the Departmental Appeals Board, as well as others weighing in on this draft rule, which lays out the regulatory framework for appropriate disincentives. It identifies the first set of proposed disincentives, which would be through CMS programs and providers participating in some of those CMS programs. But this, as the secretary made clear in the announcement, the idea is that this is a framework, and it's a framework in which future disincentives will also be identified as we think about all the different types of providers who are named as actors in the 21st Century Cures Act. So more to come there. Obviously, that's a draft rule. So comments closed on January 2nd, I think, and we will now start to process those comments and anticipate, a final rule in 2024. The other piece of information blocking that happened in 2023 was the enforcement began through the Office of Inspector General for certified technology developers and health information networks. So on September 1st, the Office of Inspector General began the period in which they will actually begin investigation enforcement. So that was an important date as well. Enforcement will begin on providers once the final rule is in place for the appropriate disincentives. As the Office of Inspector General had said in the final rule, that they won't begin investigations on providers until the appropriate disincentives are in place. So there's a little bit of what you could think of as enforcement discretion. Providers are obviously expected to be in compliance, but OIG has said that they aren't going to begin enforcement until that appropriate disincentives rule is in place. That there won't be a separate rule needed for that. Once the appropriate disincentives final rule is finalized, that will automatically then begin enforcement from the OIG side. So enough about information blocking. The other two things that I have to point to are TEFCA. For those who haven't heard, TEFCA went live on December 13th. Well, December 12th to December 14th. On December 12th, the secretary announced the 5 QHINs who have been designated, meaning that they were approved to go live. And on December 13th, they actually went live. So they were issued their certs and they started production transactions, and they are now transacting among those 5 qualified health information networks. And we've got another 2 who were approved to proceed to implementation and are now working hard on going live as well. And we expect them to go live in the first quarter of 2024. The last thing I'll point to for 2023 is in that same week, which was a very busy week for ONC, we also released our final rule called HTI-1, which had a number of provisions in it related to a number of different areas related to certification, information blocking, and importantly, a whole set of not proposals now, actually final regulations related to the use of AI in electronic health record systems. And we call that predictive decision support interventions. So that's an important set of regulations because it marks the first set of regulations in the Biden administration that are a new set of regulations addressing the very important areas of use of AI in healthcare.
Thank you. One of the questions, Micky, that I know is on a lot of our audience's minds is HTI-2. You know, what we know that you can't tell us something that hasn't happened yet. We appreciate the need to do that, but at the same time, a number of folks are saying, you know, electronic medical records with the necessary capability to support automation of prior authorization, for example. What do you see as some of the major initiatives or components that you see as being part of, to the extent you could talk about them, the work that you're doing in HTI-2?
Sure. Yeah, I mean, you're saying to me, you know, what I'm saying to my team, which is after, you know, getting all of that stuff done, you know, what have you done for me lately?
I know. We're really satisfied. It's great work, you know, but you know, thanks very much. That was yesterday's news. What about
right? Exactly. It's done. No,
what
and
have you done
we
for me
ourselves,
lately? Right.
we ourselves laid out a very aggressive, you know, roadmap because we believe that you know, all of us need to be very impatient at this point, I think, in you know, in moving forward and you know, sort of the regulatory judicious application of regulations, I think, is really important to helping us all move forward. So the unified agenda, which is the schedule of regulations, did have HTI-2 draft for November of last year. Obviously, we didn't do that in part because, you know, we're working very hard on TEFCA and HTI-1, so that, you know, that moved out a little bit. We are working very, very hard to get HTI-2 you know, through the process and available, and fully expect to have it available in the first half of 2024. A number of things that you know, that I think we did identify in the unified agenda description. We are certainly looking very hard at prior authorization now that the CMS interoperability rule is out, which is the prior authorization requirements on the payer side. Obviously, it begs the question of what does that mean on the provider side? So we're looking very hard at that. We did have an RFI, I think, as many of you know and many of you commented on, that was, you know, very informative in terms of, you know, sort of the industry desires for, you know, having something in electronic health record systems, and certainly working very closely with Alex and the CMS team on, you know, trying to figure out how we make sure that, you know, that the dream becomes a reality in terms of, you know, getting to where we all have wanted to be for a number of years in prior auth. So we're looking very hard at that. The other thing that we're also looking very hard at is public health systems as well. And I think, as we had described very briefly in that unified agenda description, we're looking very hard working with the CDC and with jurisdictions on concepts related to certification to public health IT systems as a way of helping our public health infrastructure move forward with you know, better, more standardized, more effective ways of sharing information, both you know, between the federal government and jurisdictions, but importantly, jurisdiction to jurisdiction, so they can more readily share information with each other, as well as better integration of public health agency activities and the healthcare delivery system, so that providers and public health systems can exchange information with each other.
Excellent. Thank you. We have a number of questions, and I'm going to take these a little bit out of order. Alex, Ruby Rayleigh asks that it's possible to comply with the prior auth regulation by only offering a 278 EDI transaction. Will this be used by some to avoid investment in modern API integrations? And does CMS, Health and Human Services, have a concern or thoughts on EDI versus FHIR?
So I just want to make sure that the requirements of the rule are clear, and I know it only came out yesterday, so some more to come on this. But to be clear, the rule requires a FHIR-based API for prior authorization. Payers may also offer a 278 transaction alone, or they might also offer a FHIR and 278 hybrid transaction, but the rule 100% requires the FHIR-based API. So we believe that this will help move both payers and providers to the more modern technologies that we've seen such success in implementing for prior authorization. The enforcement discretion and the way that it is, the way that it works alongside this rule is that it says that you may that we will not enforce the use of the X12-278 for prior authorization. That doesn't mean it can't be used. It just means that we will not enforce it if it isn't used. So you can go all fire, which would comply with the rule. You can do fire and X12-278 hybrid transaction. That would also be compliant with the rule. Or you can also offer an X12 only solution that would not be compliant with the rule if that's the only thing that you're offering. I hope that helps. I think I spiraled on that a little bit, but I want to make sure that that is very clear for, for meeting the requirements and making sure that we are moving to those more modern technologies. And I want to mention, so sorry to take this question on a bit of a tangent, but when we rolled the rule out yesterday, we were on site at Inova Hospital in Fairfax, Virginia. We were there with the administrator. We did a tour of the hospital. We got to hear some really interesting patient stories, hearing from providers and directly from patients about the challenges of prior authorization. And then we also got to hear from a payer who has implemented an all-fire prior authorization transaction. And they explained how the technology works to more automate the process. And they gave some preliminary data on what they're seeing in terms of increased efficiencies. And they were able to explain to the providers that were in the room about how they have taken how they are now able to process about 89% of their prior authorization requests instantaneously and give a response to the provider right there while a patient is still in the office. And the reaction to that was pretty incredible. I think it's hard to believe when you've been working on phone and fax and paper and different portals for all of these years. It's hard to believe that something like this could be integrated into your EHR workflow and give you an instant response in many cases. But the providers were very interested to hear that, and the payer was happy to share their experience. So this is the type of thing that we want to see moving forward. This is the type of technology that we want to see scaling up in the industry, and the types of efficiencies that we're hoping to introduce with this rule and with the standards that we've been all working on together for so long.
Thank you. Bill Gillis asks, Micky, what is the best path forward when you find a vendor out of compliance with rulings? And I think this is with regard to information blocking or not using the appropriate technologies as specified in the HT1 rule and was required at the beginning of last year. Can you talk a little bit about that, dealing with vendors in this case who are out of compliance with making these technologies available?
Sure. Yeah, I think there are two dimensions of that. One is that through the certification program itself. So leaving aside information blocking for a second, if a vendor is a certified vendor, they're required to be in compliance with the certification requirements, and that's both the specific technical requirements as well as the conditions of maintenance and certification. And so, if anyone believes that a vendor is not in compliance, they can submit a complaint to ONC, and that's something that we investigate. And just as a part of the certification program, we can go through a process of investigation, corrective action if needed, and even all the way to decertification if the problem is big enough and seems to be persistent and violates the certification requirements in that area. So that's one path which is independent of information blocking or stands on its own. The other, though, is with information blocking. So certified technology developers are actors in the information blocking rule and in the statute, and there is a complaint process for anyone who believes that they are experiencing information blocking by any of those actors. So if someone has what they believe to be an information blocking claim or complaint against a certified technology developer, they should submit a complaint on our portal, on the ONC portal. I think if you just Google, it's certainly easily available on our portal where you can submit a complaint. Those complaints are required to be anonymous, meaning that we hold them, ONC holds them as anonymous. So people shouldn't be concerned that that's going to be made public. That in the statute, there was a requirement that we keep those anonymous. And we also have on the portal a sort of a flow chart that shows the process for what happens to a complaint. But in short, we get the complaint, we do an initial screen to make sure that it's at least based on the fact pattern that was presented to us, could plausibly be information blocking. And most of them are, but the ones that we would screen out, for example, are someone who is making a complaint about a payer, for example. That, you know, payers are not named actors in the statute, for example. So that may be very bad customer service. If the payer was an actor, that may be that, yeah, that would be information blocking, but we do need to, say to the complaint, let the complainer know that, payers are not identified actors. So that would not be information blocking. So we're not moving that forward. So then we would take that and then pass it on to the Office of the Inspector General. Last point I would make, which, hopefully, all of you take to heart, is that the information blocking rule, the information blocking sort of paradigm is complaint driven, meaning that it was very specifically set up in statute to be something that was driven by complaints. And that's why they, required that ONC set up a portal. And we have this process of vetting those and passing those over to OIG for further investigation. The complaints that we've gotten to date, and this is available on our portal as well, we get roughly 5 a week. So not at HIPAA levels, HIPAA gets tens of thousands, a year. We get, we're getting like 5 a week roughly, but that's continued at that pace. And the vast majority of those complaints are complaints by patients against providers. Something like 85% of the complaints so far have been by patients alleging that providers are committing information blocking. So to the extent that there are complaints that anyone has about a certified technology developer, strongly encourage you to submit a complaint, and then we go through that process. I would also say that numbers count as well. So there's both severity as well as numbers, because that also sort of identifies itself as patterns. So if you've got you and your colleagues, for example, are finding that you're facing same information blocking issues with the same vendor, let's say, I would certainly suggest that everyone who is experiencing it submit a complaint, because it's both about severity as well as numbers that would sort of flag it as being an issue worthy of further investigation.
Thank you very much, both of you, for those answers. Why don't we move on to the second question that we have today? Alex, at the beginning, you mentioned how well you've been working together, ONC and CMS. Can you talk a little bit about how you do that? From those of us who are watching from the outside, we envision obviously a lot of meetings and a lot of interactions, but this is an enormously complex process with many moving parts, many actors involved. Could you share a little bit about, starting with you, Alex, about how the two agencies, the two parts of Health and Human Services and other actors work together to make these kinds of regulations happen?
Thank you for that. I will say that these are significantly huge efforts with lots of moving parts. As I mentioned when I was talking about the prior authorization rule, we have almost every part of CMS coordinating on and working on those policies to make sure that we're aligning requirements across our payer programs and bringing in the providers. But in the end, I hate to disillusion anything. I want you to still believe that these are huge efforts, because they are. But in the end, it's really, our teams are actually pretty small, and we work very closely together to make sure that we are in alignment, and that our policies are supporting one another. And sometimes that works and sometimes it doesn't. So I would say in most cases, CMS and ONC rules reinforce one another, and in some cases can be interdependent on one another. Micky just gave a really great example with the disincentives rule, that this rule was a result of policies that we've been working on since 2016, and they just finally came out last year. But CMS has many policies that rely on information exchange, and the disincentive rule puts extra teeth behind that information sharing by putting an end to information blocking. And some of the disincentives that were in that rule are based on authorities and enforcement mechanisms of CMS programs. So while ONC leads the rulemaking and the policy leadership, it's done through CMS programs and through our collaborations. So I think, it's really interesting to see that some of our policies really can't stand without the others. And so that collaboration is a critical piece. When it comes to interop and data exchange sort of more broadly, I would say oftentimes we at CMS will put out a data exchange policy, and then ONC will support those policies by introducing or enhancing technical requirements to support our policies. And then sometimes it goes the other way around, where ONC adopts a standard so that we can in turn integrate it with our policies. So again, you can see some of those interdependencies. And there's a lot of collaboration going on behind the scenes. And I think we probably more than you see, and that comes from this ongoing relationship and communication that the teams have, but also the work groups that ONC hosts. CMS takes an active part in those and contributes to the Federal Health IT Strategic Plan. So these are all efforts that we look at and work on together. So, even understanding that there's a lot of change that'll happen over the next 5 to 10 years, I would say that CMS and ONC are pretty aligned on what we envision for that time frame and how we can keep our agencies working together and moving forward to meet certain goals that we have over that time frame. And we're going to make you wait that 5 to 10 years to see what those are. You also asked about inconsistencies, though, so I do want to mention that we do try to align wherever we can. But there have been some instances, like with the prior authorization rule, where our standards get out of sync. So ONC progressed some of their standards in the HTI-1 rule, and we had proposed an earlier version in our interoperability and prior auth proposed rule. So while we had tried to implement our policies whereby our standards advance along with ONC's, in this particular instance, we got out of sync. And we do try to avoid those inconsistencies. And so that's something that we need to fix. And so we'll work with Micky's team to make sure that we can do that.
Micky, from your perspective and from the perspective of the ONC, talk a little bit with us about the collaboration with CMS.
Sure. Just building on what Alex had said, there is an ongoing, day-to-day interaction at the team level. I think the teams really just, end up working very closely together as almost a joint team in many areas, because there's so much just sort of ongoing stuff. CMS has its annual rules as well, and then things like the interoperability rule. So there's just ongoing engagement back and forth. We have a team who's, basically dedicated to working with CMS on these issues. So there's always that happens, but I will also point out that, there's stuff that bubbles up. So, Alex and I have a very healthy text channel where we're able to identify issues that, that perhaps where we think that the teams may jointly need some direction or some guidance to help accelerate, or to, to give focus, to make sure that everyone's working directionally in the ways that that we, from a higher level leadership perspective, believe that they need to be going, to set timelines and deadlines where appropriate, because everyone needs deadlines, and to make sure that that we're both thinking tactically and strategically. So we want to be thinking about the nitty-gritties of the rules, but also how do those map to CMS's longer range strategies? How does those map to ONC's and our collective HHS and industry and national interoperability roadmap? So we sort of tightly coordinate on that as well, because no single agency has full control of that. And obviously with CMS and ONC are really the primary agencies, at least as it relates to interoperability in the healthcare delivery space. So working very closely and making sure that we and we also have complementary authorities. So as Alex was pointing out, making sure that we're kind of making sure that we've got that complementary alignment. Some very particular areas also where we and I've tried to sort of emphasize this in my time here, is doing everything we can from the ONC side to support the CMS mission with everything that we can do with respect to our authorities and with interoperability and health information technology. So we a couple of areas of further collaboration, I think, are Alex had mentioned the healthcare directory. So I think, as everyone knows, we've got a directory live up and running in TEFCA. So we'll be working very closely with CMS to say, all right, how do we think about those as complementary pieces of the puzzle? If you think about the way directories work and the federated directory kind of approach that the internet uses, and that, that is, sort of the modern convention of that. When you've got a live in production directory, that can be an important piece of the puzzle, and we'll, obviously work very closely with CMS to make sure that that's aligned with the broader healthcare directory ambitions that CMS has, that, that the TEFCA directory isn't going to cover. The other area that is really important for us is with TEFCA. We've been, very explicit as we look into 2024. We're now working on FHIR enablement of in TEFCA Exchange, and anticipate that before the end of the first quarter, we will have the QHINs having approved FHIR-based exchange and an updated common agreement that embraces FHIR-based exchange among participants themselves. So API to API exchange, not brokered, what we call facilitated FHIR, not brokered by the QHINs. The reason I mention that is that that's a very important complement to what's in the CMS interoperability rule as it relates to payer APIs. So if you think about the provider access API, for example, we've explicitly been tracking and working very closely with Alex as, as they've been developing on that side, the APIs required for payers to support, to say, all right, how is TEFCA going to meet those and help to scale those? Both, scale those nationally to support the payers and what they want to be able to do. And obviously what CMS's vision is there, but also to provide that connection with providers, to be able to say, well, those payer APIs ought to be contributing to an ecosystem which is getting us to the next level of interoperability. So providers having access to claims data, and in return, payers having access to clinical data, using TEFCA for scalability and trust, to be able to, get that next level of interoperability that all of us have wanted. So that's that's just another example of the ways that our authorities and the different policies that we have turn into things that we work very closely on, explicitly having complement each other.
Terrific, thank you. One of the questions from an audience member, Alex, is, addresses the fact that commercial plans are not in the scope of the CMS final rule, interoperability and prior authorization rule, and asks, if a health plan spans commercial, Medicare, and Medicaid, would you advise for or against their implementing the prior auth automation across all of these particular aspects?
So that's a great point to clarify. So the interoperability and prior authorization rule applies to Medicare Advantage organizations, state Medicaid and CHIP agencies, Medicaid and CHIP managed care organizations, and the qualified health plans in the federally facilitated exchanges, or what we commonly refer to as marketplace plans. So it does not apply to the commercial plans, even though some of the payers that may be in Medicare Advantage or in managed care or in the qualified health plans, they may have commercial lines of business, and these policies do not extend to those. And that comes down to a lot of policy and authority reasons and various things. But to answer the question directly, we do encourage payers to implement this across their lines of business. And I would think, for one reason, I think it'll be cleaner for them and in their own operations to have this one API or this set of APIs that can function across all of their lines of business. It will help to automate and clean things up. And if you're implementing it in one place, why not roll it out to everyone? But at this point in time, while it is not required, I like to believe that these policies are going to be so efficient that everyone's going to want to use them. And we would certainly encourage and provide support to any payers that are looking to roll them out across their lines of business.
Can I just
Excellent.
add?
We have a number. Go ahead, Micky.
Yeah, as another
go ahead.
motivation for that, one of the one of the things that we've been working on in TEFCA with with payers in particular is this idea of a level playing field for exchange. Payers very much want to be able to have easy access to the clinical data that they are authorized to have access to, but that often they get friction. And they're not able to get the kind of effective and lowest cost access to that clinical information, and they would very much like TEFCA to be the avenue for them to be able to get that. One of the things that we've pointed out is that the reason the providers have been resistant is because they feel like it's a one-way street. Like it's all about clinical data to the payers, and they get very little back from the payers. And the CMS interoperability rule offers that, a beautiful opportunity for the payers to make available a FHIR API for all of their lines of business, not just the ones that are regulated by the interoperability rule, but for all of their lines of business, make that available in TEFCA as a API, a provider access API, so the provider can get access to their claims. And that allows us to establish the policy of required response on both sides at that point, to be able to say, and we're working on putting that into policy in the next version of the common agreement, which I said is coming up before the end of March, where it would explicitly say that for a payer who makes available a provider access API along the lines of the CMS interoperability rule for all their lines of business, if they make that available in TEFCA, there would then be a required response on both sides. A provider would be required to respond to a payer request for clinical information, and a payer would be required to respond to a provider request for claims information. And we're hoping that that's seen by the payers as being something that's of value to them. If they want to be able to get that easy access to the clinical data, then they have that in their hands now to be able to make that claims data available, and they'll be able to get that access.
Terrific. Let's move on to question number 3, as I know we're nearing the top of the hour. Let me make sure I clear my screen a little bit so I can see what's here. Patient access to data is increasingly important, as is making sure they understand and know how to use that data. What are ONC and CMS doing to better ensure not just that data flows, but that patients, consumers, members can control their data and know how to effectively wield that control, or to what extent patients can control that data and how they can wield that control? Micky, why don't I start with you, and then I'll go to Al.
Sure. Yeah, I mean, issues of control are always complicated, in part because within HIPAA and for treatment, payment, and operations, HIPAA explicitly doesn't give patients control in the ways that we normally think about control, right? For TPO, that information is allowed to flow without a patient's authorization. Providers are certainly welcome to respect or honor a patient's request for restricting the flow of information, but a provider is not required in HIPAA to do that. However, in a number of ways, we've tried to move forward with being able to allow patients to have better access to their information and better ability to have control over the data that's in their hands. So one way that we're doing that is through TEFCA. So with TEFCA, I keep coming back to TEFCA. With TEFCA, there is explicit individual access is a very important use case in TEFCA. But one of the things that we have put into policy, because there is no regulatory approach that we can we don't have authorities to regulate entities like apps, for example, patient-facing apps that are not subject to HIPAA. But what we can do through TEFCA is which is a commercial contract essentially, is that we have put in requirements in TEFCA that if you are an individual access provider, service provider, meaning you're an app, a patient-facing app, you essentially have to live by the HIPAA privacy and security rule. So the same rules would apply to you as appropriate, and we've written that explicitly in the common agreement. So hopefully, what that creates is an ecosystem where those who are the sources of data, like payers and providers, who are making data available to patients, which they have a right to have access to, will encourage people to do that via TEFCA because it affords them greater protections. And on the individual app side, what we would like is for that to create, sort of a way for them to distinguish themselves in a very cluttered field to be able to represent the patients. We do this through TEFCA, which means that we have to hit a higher bar in terms of the protections that we afford to you. We have to live by the HIPAA and security rules as appropriate. We also have very explicit transparency requirements if they participate in TEFCA with respect to consent, with respect to making patients aware of how their information may be used outside of the very specific, sort of transaction of just having availability information. So that's, one particular way that we're, trying to help us move forward.
Alex, from CMS's vantage point, much of what started this whole process was the introduction of the patient the consumer in addition to payers and providers that Seema Verma infamously introduced as a new way of thinking about health information exchange. Can you talk from the CMS perspective about patients' access to their data, the impact that improved prior authorization and other processes have on patients, and how they might participate in that?
Yeah, thank you. So I do want to follow up on one of Micky's points. He captured that very well. When we talk about owning or controlling data in healthcare, there really isn't a clean line. There are many reasons that providers and payers and other healthcare entities would need to exchange patient data, and they can do that under HIPAA for treatment payment operations. Again, lots of reasons why that's absolutely necessary in healthcare. But when we talk about interoperability, we always talk about getting the right data to the right place at the right time, and that includes, making it available to patients and making it available to them in a way that they can understand. So often when we're talking about interoperability and giving any sort of having internal discussions with the teams here, and we talk about patients accessing their data, or really anyone having access to data in healthcare, and why standards and interoperability are so important. It's because we want the receiving system, whether it's a provider or a patient or anyone else, to be able to intake data in a standardized way so that they can make sense of it, and they can make, have that be meaningful and actionable for them. And with patients, that has to be tailored a little bit differently than it has to be tailored for providers in many cases. And I think that there is a real shift needed in healthcare where we engage the patient more and put them more in the driver's seat. By giving them access to their data, they can make more informed decisions, and they can be in the driver's seat of their own healthcare. But that hasn't always been the case. As you mentioned, we've really had more of an uptick in that in the last 10 years or so, but and maybe even more recently than that. So there are a lot of patients that don't actively engage with their health data until they need to, and you never want to wait until you need to do it, because that's usually when you're in a tough situation or a life event. We want to make sure that patients are engaged from the beginning, that they understand and interact with their data, and I think that's a little bit of a cultural shift in healthcare. But I think with the things like the patient access API, making the data available to patients in a standardized way that they can tailor that through whatever app they choose to be most meaningful and actionable to them, that's a really good starting place. And that's where we are currently, and we're hoping to continue to work with payers as well as providers to help patients understand how to better engage in that space, and how to navigate the healthcare system.
Thank you. We are just a few minutes before the top of the hour, and we want to respect your time and your calendars. So, Alex, starting with you, any final comments that you'd like to make, given where we stand today and what we can look forward to, and what you're most excited about as we sort of move through this next stage of interoperability? What are some of your final thoughts?
Well, first I want to say thank you for this session, and for, as someone said at the beginning, sort of bookending your series with me and Micky here today. This has been really interesting to follow all of the conversations and hear the discussion. I think that what we have seen over the last decade plus is more and more interest in the way that technology can support information exchange in healthcare. We've seen a lot more acceptance of the use of standards and data exchange, less info blocking, and more understanding that this data is going to be shared, and so it needs to be done so in a meaningful and actionable way, as I said in response to the last question. So I like to think that going forward, you're going to see an exponential increase in the productivity and the production of or in standards development and in adoption of those standards. And we're going to see more where we can talk more about things like administrative transactions, like prior authorization. Whereas before we've talked about sending data from one place to another, we're now talking more about this in a bi-directional data exchange and achieving things like administrative transactions, or achieving more of a conversation between systems in healthcare. And I think that you're going to see an exponential increase in that going forward through, again, the use of those standards and hopefully in the policies that our teams can produce.
Thank you. Micky, from your vantage point.
I am more excited than when I took this job 3 years ago. I think, to me, we're kind of, rocketing out of the trough of disillusionment, and rapidly climbing the plateau of productivity. Thinking about the Gartner hype curve, and in particular, I think we're now, sort of the dream is sort of being realized in terms of all these various pieces, laying the foundation of EHRs, data standards, Fire APIs, network interoperability, being able to see all of those things come together now in a more coherent way, where they all seem like they were disparate kind of patchwork sort of things. You're sort of seeing those things come together as mechanisms, the data, the APIs, and the network interoperability, as well as the better integration now, and hopefully this more seamless integration of administrative transactions, clinical transactions, and public health. We didn't talk about public health on this, but we've got a tremendous amount going on with public health as well. We anticipate in 2024 bringing a number of jurisdictional public health agencies live on TEFCA as well, which will really be just an amazing, sort of threshold moment for interoperability, because those agencies have not participated in network interoperability to be able to get the kind of, sort of real integration of public health with the rest of the healthcare system that all of us have wanted. So really, really excited. And I think there's, we have that opportunity now that it's line of sight. It's not just this gauzy vision that, we hopefully will get there.
Well, Alex Mugge, Chief Health Informatics Officer for the Center for Medicare and Medicaid's, and Micky Tripathi, the National Coordinator for Health Information Technology. Thank you so much for spending time with us. Thank you for altering the regulatory calendar to meet this deadline of this meeting. I want to say how much I appreciate that you did that for us. All kidding aside, we are very grateful to have this ongoing conversation and collaboration with you. As you know, we are working a lot at MHDC to make these standards, these interoperability promises, reality in a number of ways in Massachusetts. So we are thrilled with the progress you've made. We are excited as hell about what's coming up. And with that, I want to thank you both for joining us. And on behalf of our audience, on behalf of our staff and our community, we wish you the best of luck in your 2024 journey. But again, thank you very much.
Thanks, Denny. And thanks everyone who participated.
Thank you all. So for those of you who are still online, we are going to remain online because I know we have a lot of questions for folks, from folks who have raised those questions, and we'd like to be able to answer them. Let me start with Janice, from your vantage point. Are there questions that we should be focusing on to address with our audience that have not yet been answered?
Yeah, I'd actually like to piggyback on the last topic that Alex and Micky covered to have a discussion about the adoption of patient access APIs and patient access to data. And the question that came through on the Q&A was framed specifically in the context of adoption of the patient access APIs by patients and payers, indicating that they weren't getting good adoption, which is something that we've heard ongoing. But the actual landscape is a little bit more complicated than that, because there's sort of if we build it, they will come issue that's happening. And a lot of the third-party apps that we've talked to have indicated that there's not enough support, discovery, there's all kinds of issues, test environments, things like that, in order to onboard different payers. And then of course there's the advertising availability to patients. So there's kind of a three-pronged issue with different groups seeing different pieces of that. And I think for each of the groups that has the question, why aren't we seeing more adoption, or why aren't more people using this, there's kind of a different answer, and all of those prongs need to be discussed holistically to really get to the issues. So I wanted to sort of put that out there. And that question, if I remember correctly, was asked anonymously, so I don't know if the person who asked it is still here. Let me double check that. Yeah, so,
Well,
but I just,
go
I'm
ahead.
sorry, go ahead, Denny.
No, I'm waiting for you.
Uh, so I don't know if the person who asked
How
that
do
is still
we
here.
engage members to use the APIs? Is that the question that
Yeah,
you're
so
looking at?
it's not just, it really needs to involve, I just want to, you know, from my perspective, it needs to be sort of a multi-pronged effort that engages the payers in not just putting an API out there, but supporting it enough that third-party apps can use it to build the applications. And then those are the apps that patients will use. The patients aren't going to use the APIs directly. So there needs to be kind of a workflow that happens. In the first question, if you're a payer, should be, does my patient access API program support the third-party apps sufficiently so that they can build applications that use this API? And then the second piece of that is am I telling patients that there are apps out there? Are those apps getting out there in a sufficient way that patients are finding them? How do we educate patients on the patient access API if they're not going to use the patient access API directly? And some of them won't know what an API is. So we don't need to tell them use the patient access API. We need to tell them there are all these apps that are now out there. But you can't tell the patients there are now all these apps that are out there until you get through that first stage of having the third-party app developers able to use the APIs.
Dave, you have your hand raised. You want to address this question?
Well, I'll give you my impression, Danny. I don't know if I can address the question, but I'll give you my impression, which is that with the bifurcated nature of healthcare data and the complexities of establishing API connections to apps, and also the prevalence of the use of what I would refer to as portal apps or portal access to essentially the same information like claims history, for example. I think we're just not there yet. You know, it's kind of like, you know, this is the beginning of the ATM story that we hear over and over again, where people kept going to the tellers until there were no more tellers. All of a sudden, you know, the ATMs became the way to do business. Now you can't find an ATM. Everybody does online banking or banking through apps. So I think we're just in that, as Micky was calling it, coming out of that trough of disillusionment up to the more adoption curve ready state, where as more and more data becomes available through single API connections. Today, in order to get all of your data, you have to have an API connection to your EHR side for your clinical data there. You have to have one for your payer side to get the claims and history data there, maybe another one for pharmacy transactions through a PBM, I'm not sure. So it's just, like I said, bifurcated nature of healthcare data and the complexities involved in establishing these connections, setting up these apps, and then maintaining them from a consumer standpoint. I just don't think we're quite ready for that complexity yet, in my opinion.
Any members of our audience have a perspective they'd like to share on this before we go to other questions?
Yeah.
So Denny, they're not set up to speak. I just have to,
Ah.
I have to
Oh,
unmute
okay.
them if they are. So if anybody would like to speak, just raise your hand and I'll unmute you.
All right.
By
I
all
do want to,
means.
we did get a chat comment, which is not public, because that's the way it's set up. That indicated that patients, and I apologize, I'm paraphrasing, so hopefully this comes across the way it was intended. Patients just want their portal access and they don't really care about the apps, which I don't think is true. And I would also note that there are plenty of patients who don't use or can't use portals. For example, many portals are not accessible to people who have visual impairments, for example. And so there are groups of people, a lot of people who are older find that they aren't interested in using the portal. Some of them may actually use phones and apps. So I think that part of the idea that the portals are the be-all end-all mechanism for patient access is a fallacy. And if you adopt that idea, then you're leaving a swath of people in the dust. And also, to Dave's point, you're also maybe looking at one mechanism as things are evolving into using other mechanisms. And
Nolan
that was
Kelly.
actually Chris, so he's available. So if he wants to comment, I apologize.
Well, let me first go to the hand raised for Nolan, and if Chris wants to raise his hand, let's get a conversation going here. Nolan, go ahead.
Hi, Denny. Yeah, thank you so much. And Janice, nice to hear your voice as well. Nolan Kelly from One Up Health. Just wanted to comment on this. We do a lot in the patient access space. And Janice, I think you're spot on. There's multiple legs to this stool, from the app community to the payer to the patient. We see a lot of payers that don't market or promote app availability to their members, and that's totally their decision. I think a lot of the stuff is the newness of it and getting organizationally comfortable, and then getting consumers comfortable. It also comes down to the value of the apps. If you have a chronic illness, you might have a vested interest in an experience that gets at your data differently. If you've had some financial issue historically, you might seek an app experience that allows you to explore your data in different ways than portals allow. And so, it's a very nuanced answer. I'll also just add that this conversation with Micky and Alex was tremendous, and they touched on a lot of things that I think are really designed to build on patient access. Patient access was step one or an early step, I should say, of a long journey here. And now these new regulations talk about bi-directional data exchange, business to business data exchange. And a lot of those capabilities need to happen or can now happen because of the patient access investments that have happened. So very nuanced market, on this topic. A lot of perspectives, but I think that this all is very much moving in the right direction. It's an exciting time, and want to thank you guys for organizing this series.
Well, thank you. Chris, your hand is raised. You are at the start of this conversation. What are your thoughts?
So, I mean, while I agree with Janice that obviously there are some portions of the population that an app would be very beneficial. I mean, the proof is in the pudding, right? So you could ask any payer in the nation, and they will all tell you the same thing, that their patient access API is going unused for the most part. I go back to my original thought is, if you want to mandate interoperability, the best way to do it is to impact provider and payer workflows, or to do things like what NCQA is doing by making colorectal cancer screening become a measure which requires clinical data look back over a 10-year period. So
right.
There's ways to push it. And the patient access API was a good first step because it introduced the technology and it got people thinking about it, and they brought in experts to be able to help them with that. But ultimately, until you're affecting workflows, you're not going to really push interoperability.
I think that's a really good point, Chris, and I'm glad you clarified that and made that brought that to our attention. I think one of the things that we see in this industry is that the expectation of technologies having enormous impact in the near term is overstated, and their impact over the intermediate and longer term is understated. We're impatient when technologies become available to see them in action. But as you point out, Chris, there are workflow requirements. There are patient, member, consumer education requirements. App availability is necessary for people to use apps, but also, we know that systems and workflows are going to evolve to make apps even more powerful. At MHDC, for example, we see less value in the exchange of information, be it between, a payer and a provider. Certainly that's important and a necessary ingredient. But the critical aspect that we focus on is what is done with that information. What workflow does that inform? What automation scenario does that enable? How do we move from data exchange as a state to the value that data exchange can enable? And some of that value will come out in the intermediate and longer term. We're impatient. We think if we build access, people will come. We think if we create apps, people will use them. And the reality is there's a convergence of a number of different needs, at least in our experience, that enables that to happen. I believe another hand is raised. I want to be sure I recognize questions from the audience. Do we have a hand raised from somebody in the audience?
Not that I see.
Denny, I actually,
Now I do.
Okay, we had another question picked out. Go ahead, Jocelyn.
Hey,
Jocelyn.
Jocelyn Keegan, Point of Care Partners. I might be a little bit spicier, I think, in a response than maybe folks have been thus far. But, I think that the nut of this is, I think that part of the reason that we've had challenges in uptake with patient access API is more that, and I think Alex spoke to this, patients assume their data is where it needs to be until they're actually in the middle of an event and they realize the data isn't flowing. And I think that, CMS starting with patient was brilliant, because I think if they had started with payer to provider, that we'd still be in a logjam and we'd still be in comment periods and people would be fighting against it. No one could object to starting with freeing data for patients for their behalf. And I think that's a really important thing we need to think about. But, I grew up in product building stuff and building sort of first to market types of solutions. And you acquire bodies like butts and seats using your application, one body at a time. And so I think we should expect that the curve here is going to be low, and we need more functionality in those APIs. So I think the addition of, more emphasis on the clinical data and more emphasis on fixing problems that are stopping people from getting care, like prior authorization, I think will add value to the workflow conversation I think that's happening here. Today, primarily what I'm going to get from my patient access API is what the payer has today, which is, maybe some clinical data, but primarily things that are EOB related. And that's not telling me anything as a patient I already don't know. But if you could tell me the status of my prior authorization, if you could give me access to clinical data that's appearing either at my payer or provider in a single application, not making me log into 3 portals, that's going to actually make me change my behavior as a patient and actually use an application.
Thank you. Jeff Coughlin has raised his hand. Jeff, go ahead. You may need to unmute your microphone.
Thanks. This has been a really great conversation, and kudos to MHDC for hosting it.
Thank you.
I think all the points that have been raised thus far have been spot on, but the only thing that I would add is there's an education component here for patients to understand that this information is now intended to be available, and who does the education, I think, is the big question. I think ONC and CMS have educational resources to a certain extent, but it kind of comes back to maybe the frontline providers to figure out how to educate patients that this information is available. Providers often don't have a lot of time to do the education, but I think that's kind of the missing piece for me, is letting patients understand and know and understand that this information is available and how they can access it.
Excellent point. Well taken. Thank you. Ferris Taylor, you have a question or raised your hand. And then Kathy, I'll go to you. Your mic may be unmuted, Ferris.
There it is. Okay. I've been trying to find that little that little icon. I think in some ways I had put in Q&A a couple of times, what are the pushbacks that ONC and CMS has heard in the 900 comments and like that? What are the landmines that we as an industry are going to face going forward? And what's been going through my mind, and I think Chris and this last comments, Jocelyn's comments, all relate to this. We've spent 40, 50, 60 years digging the hole, that leaving the patient out of the discussion. I'm surprised that the pandemic hasn't opened the door more. The typical attitude, and Denny, you and I have talked about this in the past, has been, I can do anything that I want to do. I can be a couch potato. I can eat anything that I want to eat. As a patient, when I get sick, it's the provider's job to make me better. And the pandemic hit, and the provider couldn't make us better. Number one, it was new. We didn't understand it. Number two, and I think it's a big shadow over everything, is that politics got into the middle of very basic patient education. When you're sick, stay home, wash your hands, wear a mask if you go out, those kinds of things. And that simple patient education or engagement took place during the pandemic, but now we've just slipped back into our old ways. Things have changed. Patient attitudes are different. You know, we want to share data, but I don't have to say I'm going to share my data. I know there's privacy and security concerns, but you know, I go on Amazon and I start looking for things, and pretty soon I have pop-ups of solutions that look really good. How do we get to that point, technology-wise and data-wise, that the patient is part of the provider-payer interaction? And we can't wait until I'm one of the 15 or 20% that has a serious medical condition. I need to start engaging when I'm healthy or when I'm really sick. And we're not there yet. But payers and providers, I think, are going to have to lead out in accelerating the process. Field of dreams, you build it, they will come. They haven't come because we haven't built it. That's just a comment. I don't know if I'm on track or not, but it's frustrating to hear the discussion year after year after year. And I think it's the same discussion that we've been having.
Well, thank you, Ferris. And I think those are very good points. Why don't, Kathy, you had your hand raised. Kathy Rao, did you have a question or a comment?
Yeah, Jenny, can you hear me?
I hear you loud and clear.
There you go. So I wanted to follow up, and of course, you know the work that we do at Health Data Viz, and I wanted to say several things. One is an anecdote. Many years ago, when I first went into my electronic health portal record to look at my, my annual results with my doctor, it said, click here for more information. So I had a question about my lab results. And when I clicked it, it just took me to this random data dictionary. And the first thing was autopsy. And it told me about autopsy. And I don't mind telling you that freaked me out. Like, what the hell is this?
What are they not telling me, right?
Yeah, what are they not telling me? And I sent a note back through. Anyway, so this is leading up to partly what Jocelyn said and a few other people said. In our work, we are seeing a lot of apps that are emerging, especially in the behavioral health space, in like obesity, diabetes management, those chronic diseases. But you can't just drive people to these apps. You have to make them, Jocelyn, I believe I'm saying Jocelyn was the one who noted this. You have to make them accessible and usable in plain language. You can't be talking in a language that people don't understand. And we have all this asymmetrical knowledge about, health and healthcare and all this lingo. And I'm a highly educated consumer, and I'm still Googling things all the time when I go in and look at my lab results, or I look at, my annual results. And so I would just remind all of us, the regs are great, everything is great, but it's also about human cognition and design and making these things so that people can use them. Because we all know if we go onto a bad website and it doesn't work, we're out. And I just heard a study that, we're spending no more than 47 seconds on a page now, and then we're gone. We're on to something else. So if we're talking in gobbledygook and we have apps that are not usable because we haven't adopted, an approach that's human-centered, it's not going to happen.
Thank you. That's really valuable. And it does get to, the fact that and this is what we believe, that this is an iterative process where people who have particular needs, if they find an app that is very good for what they need, that's going to become an important vehicle for them. If they find one that is impenetrable, functions poorly, they'll dump that and they'll move to something else. So, we're only starting to see what's called a patient-centered health data economy starting to emerge. But once that economy starts to emerge more fully, the market for apps that target and focus on patients with particular conditions, support for family caregivers, a whole range of uses. They're going to become the means by which providers and payers are going to enable access to their systems. We know that portals are the way we do it now. We used to go to our bank, and maybe some of us still do, to check our balances, but we also have apps like Mint, Credit Karma, and others that look at our bank, look at other banks that we might use, our 401k, our investments, our credit cards, and we pick the ones that work best for us and that enable us to get done what we want. And that's an iterative process between sort of understanding demand, improving supply, refining, understanding demand further, continuing to improve the availability of apps. So we're excited, but we see ourselves at the beginning of that journey, just coming out of the trough of disillusion, as Micky said.
And if I may, I would just
Go
say
ahead.
the thing that I found wildly exciting is public health data on TEFCA. Yay.
It's true. It's absolutely true. We look at public health as sort of a separate world. And the reality is, you know, especially in Massachusetts, we need to bring public and private healthcare together. And doing it at the level of data interoperability and data standardization is a great place to start. And I agree. I'm excited about that strategic direction for ONC going forward. Susan Clark had an excellent comment. I'm happy to read it. If Susan, you want to talk a little bit about it, we would love to hear from you. And you're on mute.
There we go. Okay. Thank you for noting it. So I recently started working at Direct Trust a few months ago and really understanding the power of accreditation where accreditation doesn't exist. So since most apps live in outside of HIPAA and in FTC world, and we've been talking to a lot of other organizations that are trying to figure out that whole, I think Nolan mentioned about what's the quality of this app? And at least our little piece of the world could be, how do we at least give assurance to users this one is safe, or to payers? I heard that when I worked with Medicaid, they didn't want to put it out because, I'm sorry, I ran to my computer and I heard you were talking to me, so I'm out of breath. But anyway, that when I was working with a Medicaid payer, that they were like, ooh, well, we don't want to advertise it because we don't know what apps to tell them to use. So working with Karen and Code of Conduct and continuing to develop methods to demonstrate for payers and consumers and providers, like what apps are good or insecure.
All right.
Excellent.
And I'd like to
thank you.
jump in with a
Janice,
final,
go ahead.
I'd like to jump in with a final question / comment. I know we only have a couple of minutes left, but one of the questions and comments that we got was kind of ties this up very nicely. There was a person who commented that they're very frustrated that they have to go to multiple portals when they see multiple provider. And this entire landscape is sort of designed to solve that problem to some extent. The provider access APIs will bring provider data, which is part of the interoperability and prior auth rule that got released yesterday. Will bring data from other providers into your provider data stores, so long as you can show that you have a relationship with the patient. Third-party apps may be on mobile, but they can also be on a computer. So there could be a third-party app that's using the patient access APIs to present a portal that encompasses all of your data that's on a web browser. And it doesn't have to be an app, but that's what a lot of the apps right now do, is actually do that combination of multiple providers. And so that's sort of what the general access app is right now. And so I think that this idea of having to go as a patient, having to go to each place separately, is really at the highest level what we're trying to solve with all of this. Having all of the data that you need as a patient available in one place, whether that's in a application that looks and acts like a portal, whether that's on a phone app, whether that's through some other mechanism that we haven't even thought of yet, and having that contain all of the data that you need about your care about your healthcare related finances, about prior authorization, etc., in one place that you can get at the place of your choice using the interface that you prefer. And that, I think, is the grand scheme goal of everything that we've been talking about in this.
Thank you. I agree. Any other comments? We're nearing the bottom of the hour. We've just got a minute left. Any final comments from any members of the audience? Jonathan, you've raised your hand. You're
Yeah.
on mute. There you go.
What I just heard, I have specialists at MGB, at Leahy, at Atrius. I get an MRI at Shields. They all see each other's stuff. When I go to every visit, they can read it. They tell me, they can check it. Aren't we already there?
Well, in some ways we are, and in some ways we aren't. You know, there are organizations who are connected through one of the major HIEs or one of the major EHR-sponsored health information services providers, you know, the Care Qualities, Care Everywheres of the world, but there are many who are not.
And most of those are
and
National Brigham Works too.
Yeah, and there's you know, many who are outside of the large health systems who are not connected. But certainly for some of us, the experience of our physicians and our clinicians sharing information is one that we encounter. One of the things that we don't encounter is that when we go on to our physician's portal, our practices portal, or the hospital portal, we don't see everything that all those doctors see. And that's where we have some differences, but it's a very good question. Thank you for raising that. Ladies and gentlemen, this has been great. We really appreciate your staying around and raising questions and making your points known. We're a consortium. We're all about bringing people together and advancing the knowledge of our community as it relates to data standards, interoperability, automation, et cetera. And I want to thank you for joining us. This has been a great series. We'll keep you posted as to upcoming presentations and discussions that MHDC will be hosting. But thank you very much for joining us today. And if you'd like to learn more, please check out our website at mahealthdata.org. And with that, we're adjourned. Thank you very much.